is from Triage Cancer, which is a nonprofit organization that believes that everyone should have access to the resources needed to navigate and manage insurance, healthcare, and finances. They provide education on the practical and legal issues that may impact individuals and their caregivers. And we were really lucky and had the pleasure of having Monica Bryant at our last year's vote meeting. And we're very, very thankful to have you here again today, Monica. So thank you very much for being here, and we welcome you to get started.
Yeah. So I'm delighted to be here this afternoon to talk a little bit about insurance and finances. As was mentioned, my name is Monica Bryant, and I am a cancer rights attorney. I'm the chief operating officer for a nonprofit called Triage Cancer. And I wanted to just spend a few minutes talking to you about Triage Cancer and the resources that we provide, because even though we're going to spend an hour together today, you may end up having questions after the fact or questions about other topics. And if we can be a resource to you, we definitely want you to know where to find that information. So Triage Cancer is a national nonprofit organization that provides education on all of the practical and legal issues that can arise after a diagnosis of a serious illness. Now, obviously, we talk about a lot of these issues through the lens of cancer, but really they are applicable across illnesses. And so everything that I talk about today is applicable regardless of what somebody might be diagnosed with. And to be totally honest, it's probably applicable to most Americans. It's just not something that we end up talking a lot about. So with that, we provide this education in several different ways. So we participate in educational events all over the country. Back when we used to all be traveling, we would do these in person, but we've obviously done quite a bit virtually. We also host events ourselves, and some of the events that we host are our Triage Cancer conferences, and anybody is welcome to attend these events. They're really open to anybody in the community that wants to learn more about these practical and legal issues. And we're actually going to be hosting another one this year virtually on October 3rd, so feel free to sign up and join us on that date. And then we host monthly webinars, and these are on a variety of topics. We just did one about coping with cancer, which is about psychosocial care. We also host them on prescription drugs and insurance. And then in addition to hosting them live, we record them so that they can continue to be a resource for anybody who's interested in learning, and those are all available on our website. We also know that these legal topics can be a lot to digest, especially when there's so much information to learn already. And so we create these quick guides and checklists, and they're designed to be sort of a snapshot or bite-sized pieces of information. You can download them for free on our website, or if you are with a support group or a healthcare professional, you can order hard copies as well on our website. And you're going to see throughout today's presentation, I've included the links to the relevant quick guides on various slides. And those slides are now downloadable on the Slack channel for insurance and disability. Now, you're also going to hear me talk about federal laws today, in addition to state laws, because where you live can impact what rights you have access to. So we have a chart of state laws on our website on employment issues, health insurance issues, disability insurance issues. And so this is just a screenshot of those, so that I might give you examples today, but then you can go to those charts of state laws to find out what's happening in your state. And then we know people learn in different ways. And so some people just aren't going to read even a bite-sized piece of information. And we've created these animated videos on a variety of topics. Pertinent to today are going to be the videos on health insurance and how to pick a plan, as well as dealing with side effects at work. These videos are about anywhere between 3 to 6 minutes, depending on the video, and they're available in English and Spanish with subtitles. And just this month, we released one on supporting caregivers. So it's specifically around the employment rights for individuals who are acting as caregivers. Now, over the many years of me doing this work, people would say things like, I wish I could just put you in my pocket and carry you around. So whenever I had a question, I could pull you out and ask you the question. And since we haven't created that technology yet, we did the next best thing in creating a site called cancerfinances.org. And on this site, it's all of the topics that relate to somebody's finances when they've been diagnosed with a serious illness. So it's about health insurance and employment rights and disability insurance. But what's unique about this particular site is it asks the user a series of questions, and then based on the answers to those questions, it takes them to targeted information. So it tries to simplify the process. And again, it's called cancerfinances.org, but it really could be applicable to anybody. And then finally, you're going to hear me talk a little bit about late breaking news and things that are happening right now with respect to healthcare and employment rights. But where we include that information is our educational blog. So anytime there's late breaking news or information or new resources, we put that in our blog, and we'll also put it out in our monthly newsletter. So again, I just wanted to tell you a little bit about us so that if you are looking for more in-depth information or want to hear something that I say tonight again, you can go. The financial toxicity after serious illness has become more and more commonplace in the conversations. And at Triage Cancer, we really believe that if we can catch people a little bit further upstream, we can actually help people avoid some of the financial struggles that come when dealing with a serious illness. And this is just a visualization of all of the questions, or many of the questions, that can be asked of someone, regardless of where they are in their care continuum, to try to mitigate or avoid the financial toxicity. I realize it's super hard to read and it's probably going to be impossible on the printouts, but if you go to this link at the bottom of the screen, you can actually get a full-size version downloadable. And on the left-hand side, it's all of these questions, and on the right-hand side, it's all of the resources that we have to help you either answer the question or deal with the answers to the questions. But we know that health insurance status has a direct correlation to somebody's financial health and physical health and mental health. So how do we figure out how to get people the best health insurance for them? Well, it starts off with understanding health insurance. And I have to say, we joke a lot in the office that health insurance and finances should be something that's taught in high school, because everybody needs to understand how to navigate these things, but we're rarely ever taught how. And typically it's through trial and error and sort of learning by fire that we figure all of this out. And so if you feel like you don't really have a great grasp on health insurance and how health insurance works, you are definitely not alone. So there have been numerous studies about people's understanding of their health insurance. And in these studies, we found that less than a quarter of people understood the terms that were being used in their policy. A particular study that was looking at people who get their insurance through an employer, only 50% of them knew what they were paying to have health insurance, which is absolutely crazy when you stop and think about it. Can you think of anything else that you pay for on a monthly basis where you have no idea what it's costing you? And yet that's the case when it comes to health insurance. So I'm going to start off with some terms, and these are frequently used terms, but they're often misunderstood. And so I just want to make sure that we're all on the same page before moving forward. So the first term with respect to cost is your premium, and it's something that you have to pay monthly just to have health insurance. You pay this amount whether you go to the doctor or not. It's like having car insurance but never actually getting into an accident all year. But then there are some extra costs when you actually go and use your health insurance. And I apologize, there's something a little bit wonky with the slide where the image is covering this. So I will, Jordan, I will PDF a new copy so that those can be uploaded as soon as my presentation is over. So when we talk about the deductible, that is a fixed dollar amount that somebody has to pay out of pocket before their health insurance company starts paying their share of the costs. This deductible is going to vary plan to plan. So somebody might have a $0 deductible, somebody might have a $10,000 deductible. But again, it's that fixed dollar amount, and you know what that amount is going to be at the beginning of the year. Now, the cost share, or the co-insurance, is the difference between what the health insurance company is responsible for paying for and what you're responsible for paying for once you've met your deductible. So it's literally a sharing of the cost, and this is going to be a percentage. So for example, if you have an 80-20 plan, that means that once you've met your deductible, the insurance company picks up 80% of the costs and you're responsible for 20%. Now, there is sometimes also another payment that you have to make, and it's again a fixed dollar amount each time you get care. And this is a co-payment. So it's going to vary plan to plan, but for example, you could have a $25 copayment every time you go and see the doctor, or a $10 copayment when you pick up generic medications. Finally, the out-of-pocket maximum. Now, the out-of-pocket maximum is theoretically the most that you're going to pay out of pocket for your care for the year. And the way you reach the out-of-pocket maximum is a math problem. So you add up everything you've paid towards your deductible, everything you've paid towards your copayments, and everything you've paid towards your coinsurance to get to that out-of-pocket maximum. So it's everything that you've paid out of pocket except that monthly premium. This is probably one of the most important things that somebody with a serious illness can understand about their insurance, because chances are you're going to meet your out-of-pocket maximum if you're in active treatment for something. Now, the devil's in the details with this, of course. So typically, only in-network services are going to be counted towards that out-of-pocket maximum. And if you have an employer-sponsored plan, they may actually carve other things out of this out-of-pocket maximum. So for example, my employer-sponsored plan carves out copayments. So the way I reach my out-of-pocket is by adding up the deductible and the coinsurance. So it does vary plan to plan, so you need to know exactly how your plan operates. But generally speaking, this is how you get there. So let me give you an example. Meet Dan or David. David has a plan with a $2,000 deductible, and it's an 80-20 plan with an $8,000 out-of-pocket maximum. He spends some time in the hospital and ends up with a $102,000 hospital bill, and he's got no other care yet in the year. So what does he have to pay? Well, the very first thing you always have to pay is that deductible. So we subtract the deductible from the bill and we're left with $100,000. Then he has a coinsurance of $20,000. Well, $20,000 of $100,000 is $20,000. But does he have to pay that whole $20,000? I hope you all are sitting at home saying no, because his out-of-pocket maximum is $8,000. So since he's already paid $2,000 towards that out-of-pocket maximum, he has to pay another $6,000 to meet that out-of-pocket maximum. And the rest of that $20,000 bill is the responsibility of the insurance company. So I am by no means saying that $8,000 isn't a lot of money. Of course it is. But when we start thinking about what it would be if there was no out-of-pocket maximum, we're talking about $20,000, or what it would be without insurance at all at $102,000, $8,000 starts to sound a little bit more reasonable. Now, if you want to hear any of that information again with respect to the terms or this particular case study, that is what's included in our animated video on health insurance basics. Now, this concept works exactly the same way when somebody has a family plan that has a family out-of-pocket maximum. So meet Mike. Mike has a plan with a $500 deductible, a $10,200 family out-of-pocket maximum. It's an 80-20 coinsurance, and it covers Mike, his wife, and his 3 children. From January to June, occasionally somebody gets sick and goes to the doctor. So Mike has now paid his $500 deductible. The co-pays and the 20%, which add up to $1,200 towards their out-of-pocket maximum. Then one of the kids breaks their leg badly. The hospital bill comes into about $40,000, and there's a lot of follow-up care and maybe even additional surgery. Of the $40,000, how much does he have to pay? And I've given you the answer here because we're not in person together. But the way you get to that is you take the out-of-pocket maximum that they've have as a family, you subtract everything they've all paid out of pocket so far in deductibles, copays, and coinsurances, and then you figure out how much you have left to meet the family out-of-pocket maximum. So in this case, Mike needs to pay another $9,000 to reach his family out-of-pocket maximum. The following month, another kid has a bad ear infection and the doctor's bill is $700. How much of that does he have to pay? None, because they went in network and they've already met the family out-of-pocket maximum. So why it's so useful to understand this information is if somebody has met their out-of-pocket maximum, either for themselves or for the family, it's wise to think about any other care that they might need for the rest of the year and get it in that year rather than waiting until January when this all starts over at 0. Now, I am not suggesting that people get care that they don't need, of course, but oftentimes there's things we put off or tests or scans or screenings that we just don't really want to deal with. But if you've met your out-of-pocket maximum, now is the time to do it. Now, one of the realities of our system is that insurance companies will deny claims. What's important for people to recognize is that as consumers, we don't have to take no for an answer because we have the appeals process. Now, generally speaking, there's 2 types of appeals. There's an internal appeals process where you go through the insurance company, but thanks to the ACA and a couple of other laws, there's now also an external appeals process, also known as an independent medical review. So that's an independent entity that's going to look at the case and decide whether or not the insurance company should have paid it. Now, what's crazy about this is of all of the claims, the millions of claims that get denied a year, only 0.05% of people actually appeal those claims. Now, what's even crazier is of the people who appealed, somewhere between 40 and 60% of those appeals are decided in favor of the patient. So that means on average, the insurance company is getting it wrong when they're denying coverage about 50% of the time. So we really want people, when they're thinking about how do we financially manage these illnesses and this care, to be thinking about things like the appeals process if they get a claim denial before they just figure out how to try to pay the bill. Now, we have a webinar on appeals. We also have a quick guide on appeals if you'd like some more information on that. Now, the Patient Protection and Affordable Care Act, or the ACA, also known as Obamacare, was game-changing for anybody with a serious illness. And it did several things. It's a huge law. It touches every aspect of our healthcare system. But perhaps most significantly is it did these 2 things. The first thing it did was it limited what insurance companies can look at when they're deciding what they're going to charge someone for their health insurance, which is referred to as premium rating. So now insurance companies can only look at, are you buying an individual plan or a family plan, your geographic location, your age, and if you use tobacco. So what you don't see in that list is pre-existing conditions cannot be used to decide how much someone's going to get charged, or gender. Prior to the ACA, women were charged more for health insurance than men. Now, the ACA went one step further and said that as of January 1st of 2014, insurance companies can no longer deny selling somebody a policy or covering claims related to a pre-existing condition. As I'm sure you are all well aware, this is game-changing for anybody with a serious illness, or actually not even a serious illness, because what insurance companies were counting as pre-existing conditions ran the gamut from severe acne to pregnancy to cancer. So really, this was game-changing for millions of Americans. Now, over the last couple of years, there have been several efforts to repeal the ACA, and when particular members of Congress and other elected officials were saying that they wanted to repeal the ACA, they said, oh, but we like the pre-existing condition protections. But when pushed further, what we learned was that what they were talking about was number 2, not number 1. The problem with that is if you take away number 1, it's not actually protecting my access to health insurance if they can charge me whatever they want once I have a pre-existing condition. So in our opinion, in order to truly continue to be a strong protection, these 2 pieces have to stay coupled together. Now, there's been a whole host of things happening where there's been a chipping away of these rights at the state level. And if you'd like more information about any of that, we have several blogs included on our blog. So I'm so sorry. Apparently when I shared my screen, all of the slides got a little bit wonky. So forgive me for that. Now, Medicaid is a federal health insurance program that was designed to provide coverage for individuals who had a low income and a low resource level and could walk through one of these 4 doors. Typically, the people that I'm talking to in the cancer community are walking through the age blind disabled door. Now, I've recognized that as a terrible name for a program. It is in quotes for a reason. We did not come up with it. But there were a couple of challenges with this. First of all, if somebody had a low income but maybe had a retirement account from a previous job that was over $2,000, they would get kicked out of eligibility, or they'd have to spend all of that before they become eligible. Also, with the age blind and disabled program, it's the highest standard of disability that exists, and so it can sometimes be very challenging to get access that way. So the ACA actually created a 5th door into the Medicaid program for individuals who had incomes at or below 138% of the federal poverty level, which in dollar figures, we're talking 17. No asset with this. So the original 4 doors of Medicaid still exist and continue to exist. The ACA just created an additional door that is easier for people who just have lower incomes to get into the program. Now, this was supposed to happen across the country, but the Supreme Court got their hands on the law in 2012 and essentially made this voluntary for states. And so we have a situation where 37 states have expanded, 14 have not. And the 14 that have not expanded represent about 5 million people that could have had access to health care or health coverage that don't because their states didn't expand. And this is something that is ever changing. And so there are several states that actually have Medicaid expansion on their ballots this fall. States move back and forth as new governors are elected and new legislatures are elected. So this information changes quite frequently, actually. Now, the ACA created a second option for accessing health insurance, and they did that through the state health insurance marketplaces. When the law was originally passed, these were referred to as exchanges, but it turns out no one knew what that meant. People don't really understand marketplaces either. The best way for me to talk about these is to compare them to a health insurance shopping mall or Amazon for health insurance. What you are buying in the marketplaces is actually coverage from private health insurance companies. But there are some benefits to buying through the marketplace. So certainly there's some quality control involved, but also there is a cap on the out-of-pocket maximum for the family and for an individual. There's also some financial help available. So there's 2 types of financial help. There's premium tax credits, which lower the amount that you're going to pay monthly just to get the health insurance. And then there are cost sharing subsidies, which will lower things like deductibles and co-payments. Now, one of the other benefits of the marketplace is that there was some standardization included. So there are 4 main types of plans that you can purchase. And they're categorized by cost share. So a bronze plan is one that has a 60-40 cost share. Silver is 70-30, gold is 80-20, platinum is 90-10. With bronze, you're going to have the lowest monthly costs, but the highest out-of-pocket maximum. Platinum plans are going to have the highest monthly cost, but the lowest out-of-pocket maximum. So what's useful about this is somebody could say, you know, I've been diagnosed and I see the doctor quite frequently and I need pretty expensive scans. So I want to make sure that I have at least 80% coverage. So only show me the gold and the platinum plans. Conversely, someone who's super healthy could say, just show me the bronze plans because I never go to the doctor. I just need basic coverage. So it's like Amazon. If you're shopping for a black sweater, you don't have to sort through the red and the green and the white ones. Now, when it comes to the financial assistance, it's based on household size and income level. And in states that have expanded their Medicaid programs, if somebody has an income at or below 138% of the federal poverty level, they'll be eligible for Medicaid. If they have an income between 138 and 400%, they'll have access to a premium tax credit. Remember, that's to reduce the monthly premium just to have health insurance. Then if you have an income between 138 and 250 and you choose a silver plan, you'll also have access to a cost sharing subsidy. Now it looks a little different in states that didn't expand because that's no longer an option, but now the subsidies go all the way down to 100%. The challenge with this is it's the premium tax credit that helps you buy the insurance plan. The subsidies are only useful once you have the insurance plan. So in their decision, the Supreme Court actually created a disparity that the ACA never intended when it was originally written. Now, when you can enroll in coverage is going to be determined by what plan you have. So Medicaid applications are accepted year-round. As soon as somebody becomes eligible, they can apply and their coverage will begin. With the Marketplace, it is a calendar year plan, and open enrollment is always in the prior fall. So for this coming year, if someone lives in a state that has a federally run Marketplace, the open enrollment is going to go from November 1st to December 15th of 2020. But even if you pick a plan November 1st, that plan doesn't start until January 1st. So you want to try to maintain coverage through the fall and winter until January 1st. Now, I said federally run programs or marketplaces because there are some states like California, for example, that's running their own marketplace. And traditionally, those states have actually had longer open enrollment. So if you are interested in knowing what's going on in your state, you can check that chart of state laws. Now, unfortunately, I didn't have a lot of time to talk about Medicare today, but if that is something that you are interested in, we definitely have an archived webinar on our website. We also have a live one coming up this September, and then a whole host of quick guides and information on our website. But open enrollment for Medicare is every single year from October 15th to December 7th. Again, they're for calendar year plans, so they won't start until January 1st. Now, if you have an employer-sponsored plan, it's best to check with your employer because they can vary with respect to open enrollments. Oftentimes, they will have a fall open enrollment so that the plan can start January 1st, similar to the Marketplace. Now, thankfully, the ACA recognized that things don't just happen during open enrollment, and they created a special enrollment period. So if somebody has a life-changing event, where they're losing minimum essential coverage, or they've aged out of their parents' policy, they actually have 60 days to enroll in a Marketplace plan. So what that means now is that if somebody is in a position where they're losing their employer-sponsored health insurance, this is insurance given through a job, they actually have 4 different options potentially. The first is electing COBRA or state COBRA, and this is where you can keep the exact same health insurance you had through your employer. The next is a totally new plan in the Marketplace during special enrollment. The next might be another group plan, either through a spouse at work, or if you're under the age of 26, potentially a parent's plan. We'd want to make sure that the employer also had a special enrollment period. And then finally, based on circumstances, maybe now you're eligible for Medicaid or Medicare. So the trick with all of this, though, is that you have to pick a lane and stay in it until the next open enrollment period. What we see happen a lot is someone will say, oh, okay, I was handed COBRA. COBRA sounds good. I'll take COBRA. Oh my gosh, COBRA is so expensive. I'm 3 months in. Can I drop COBRA and get a Marketplace plan? And the answer is no, unless it's open enrollment. So that begs the question, if I now have 4 lanes to drive in, how do I make those determinations? How do I compare between 2 different plans? I'm going to give you an example using the Marketplace, but this same analysis works if you're comparing 2 Marketplace plans, if you're comparing 2 plans provided by an employer, if you're trying to decide, do I take my employer plan or do I pick a Marketplace plan? Because sometimes Marketplace plans are actually better. Or if I'm trying to decide between 2 Medicare plans. It's the exact same analysis that I'm about to walk you through. So here's a situation where someone has the ability to choose between 3 different plans. The first is a bronze plan with a $173 monthly premium, a $6,000 deductible, and a $6,000 out-of-pocket maximum. A silver plan with a $271 monthly premium, a $2,500 deductible, and a $5,200 out-of-pocket maximum. And a platinum plan with a almost $400 a month monthly premium, a $0 deductible, and a $1,150 out-of-pocket maximum. So can you tell just by looking at this information, which is going to be the most affordable plan, assuming that you're going to hit the out-of-pocket maximum? Now, normally I'm hoping that I see, shaking heads, because I certainly can't. You actually have to do the math. And the way that you do the math is you take the monthly premium and you multiply it times 12, and then you add the out-of-pocket maximum. And when you do that for all three of these plans, you can see that the platinum plan that looks really expensive with its monthly premium actually ends up being about $2,000 cheaper come the end of the year. Now, we do this all over the country. We do pull the numbers periodically from marketplaces. It never comes out the same. Sometimes the bronze plan is cheapest, sometimes it's the silver or the gold. But the point is that you can't just look at that monthly premium and get sticker shock, because it's not telling you the full picture. Another thing that's really helpful to look at is the deductible. So even if somebody were to pick that bronze plan, that's a $6,000 deductible. That is $6,000 that someone has to come up with before that plan even starts picking up 60% of that person's healthcare. So that's, for most of us, writing a $6,000 check is harder than coming up with an extra $200 a month. So, which is where the platinum plan is with a $0 deductible. So that plan starts picking up 90% right away. So it's really important for people not to just get stuck on that monthly premium without looking at all of the other numbers associated with the plan. Excuse me. But cost is only part of the picture. You can have the most affordable plan that is out there, but if it doesn't cover your doctors or your hospitals or your prescription drugs, it's not actually the best plan for you. So very important to check networks and prescription drug coverage as well. And unfortunately, this is not a one-time chore. We actually have to make these decisions every single year to make sure that we have the best plan for us coming up. And as your treatment changes, you may need different things. You may switch to different doctors or different meds. And so depending on what's happening, you should be looking at your options every single year. Now, I do just have to mention there has been an increase in the sale of short-term plans, and these are plans that last less than a calendar year. They seem very affordable on their face value because the monthly premiums are really cheap, but the problem is that they don't have to comply with the ACA, which means that they can exclude whole categories of care like prescription drugs, and then they can end mid-year, and they don't trigger a special enrollment period. And so people are effectively left uninsured until January 1st of the next year. And I just want to bring this up because we're seeing more and more people in the cancer community get stuck in these short-term plans because they aren't aware that what they're buying isn't comprehensive coverage. I also just want to mention today that there is currently a case before the US Supreme Court called California v. Texas. And this court case is for the Supreme Court to decide whether or not the ACA is constitutional. If the Supreme Court decides that the ACA is not constitutional, everything that I've talked about today disappears. The ability for someone with a pre-existing condition to be guaranteed health insurance, the ability or the limitations on health insurance companies to only look at 4 things when they're deciding what they're going to cost, the marketplaces, the Medicaid expansion, tons of improvements to Medicare. And just last Thursday, the Trump administration submitted a brief to the Supreme Court urging the Supreme Court to rule the ACA unconstitutional. And so the case likely won't be decided before this election, but if this is something that you care about, I definitely recommend that you reach out to your elected officials and let them know how a decision one way or the other would impact you and the communities that you live in. And we have tons of resources on legislative advocacy on our website if you're interested in getting more involved. So I want to switch gears in the last half of the presentation to talk about work. What we typically find is that when it comes to work, individuals who've been diagnosed with a serious illness are often battling assumptions. So their own assumptions that they can't work and there's nothing that can help them, assumptions from employers that they can't work and that there's nothing that can be helpful, and definitely assumptions from healthcare professionals that someone can't or wouldn't want to work and they should just be out on disability. And that isn't always the case. And we want to make sure that if that isn't the case and people do want to work, that they understand that there are some tools that can be helpful. And the tools that I'm referring to are often found in the law. So there are several places that somebody can go to look for their employment rights. There are fair employment laws, both federal and state, and these provide protections against discrimination and an additional tool called a reasonable accommodation. There are also federal and state leave laws. And then if you are an employee that works under or is a union and has a bargaining agreement, those contracts will also provide some information about the rights and benefits that you're entitled to, because they may actually be different from the federal law. But the reality is that the law is just the bare minimum of what employers have to provide, and that many employers are actually more generous than that bare minimum. For most of us, if we have access to sick time or paid vacation time, that's because an employer has decided to make that policy, not because it's required under the law. There are a handful of states and cities that do have some paid sick leave, but it is minimal. So where can somebody go to find out what rights their employer is providing? Generally, some sort of policy and procedures manual or employee handbook. Every employer handles this a little bit differently. Some are very formalized and you actually get a handbook. Some are things where it's like an online drive. Sometimes there isn't anything written down at all. But if there is something written down, it's helpful to look at what benefits you're entitled to. Do you have access to an employer-sponsored disability insurance policy, health insurance? Is there a policy for asking for medical leave or asking for reasonable accommodations? Because if there's a policy in place, it's almost always easier to follow that policy or process than to reinvent the wheel yourself. Now, the Americans with Disabilities Act, or the ADA, you may have heard of it in the past. Most people are familiar with it because it ramps into buildings and accessible parking spots outside of businesses. But it also did a lot in the employment arena as well. And Title I is the part of the law that provides protections in employment. And like many of the laws that I talk about, there are some eligibility requirements or hurdles that somebody has to clear in order to use the ADA's protections. The first is that you have to work for a private employer with 15 or more employees, or work for a state or local government of any size. If you are a federal employee, you have some very similar rights, it's just under a different law. In addition to working for a large enough employer, you have to be a qualified individual, which means that you can perform the essential functions of the job, but you can get help doing that through something called a reasonable accommodation, which I'll get back to. And then finally, you have to have a disability under the ADA's definition. Now, there's a couple of points I want to make right now. The first is that I talk to a lot of people in my line of work, and sometimes there is pushback or a hesitation because they don't identify with having a disability. They have an illness or a medical condition, not a disability. So I really urge people not to get caught up in the language here. I absolutely agree, words matter, but think of it this way. 435 members of Congress needed a word to use in this law, and what they came up with was disability. And so I don't want people to miss out on the benefits and the tools that the ADA provides because they don't necessarily associate with that word. So with that caveat, the other piece is that every time I talk about disability in various contexts, it could have a different definition. So when we're talking specifically about the ADA, the definition of a disability is a physical or mental impairment that substantially limits one or more major life activities. I realize it's a mouthful, so let's break it down. Somebody has a physical or mental condition, and that condition is impacting something called a major life activity, and it's doing so substantially. So what are major life activities? Anything that someone in the average population can do with little or no difficulty. Walking, talking, eating, breathing, operation of major bodily functions. Those are all major life activities. And it could be that one major life activity is being substantially limited, or it could be that a whole bunch of major life activities are being limited, and that's what gives rise to the disability. Now, in a lot of situations, it isn't necessarily the condition or the illness itself that causes the disability, but many times it is the side effects from treatment. So keep that in mind as well. So when we're talking about the ADA, once we figured out that somebody is in fact able to use its protections, there are 4 ways to use it. The first is that you currently have the disability. The second is that you have a history of having the disability. So maybe you're not currently in active treatment, but you have that history. The third is being regarded as having a disability. And this isn't about you or your capacity at all, but rather it's about the employer's perception of you, and they're perceiving you as having a disability. And then finally, it could be based on your association with a person with a disability. And this is where caregivers might be able to get some protections. Now, what's really interesting about the ADA is that it applies to all phases of employment. So even before somebody gets a job, if they're eligible to use the ADA, they're protected in the job search process. So think in interviews. And it goes all the way through hiring, promotions, benefits, and firing. Now, in all of these circumstances, so somebody currently has the disability history regarded as or as a caregiver, they're protected against discrimination. But for people who currently have a disability or who have a history of having a disability, in addition to being protected from discrimination, they're also entitled to this thing called a reasonable accommodation. Now, I think reasonable accommodations are one of the most important tools for anybody with a serious illness that's trying to work. So what is it? It's any change in the work environment or in the way that things are customarily done that enables an individual with a disability to enjoy equal employment opportunities. Super clear, right? I know. The best way to talk about reasonable accommodations is with examples, and they can really be put into 3 different categories. The first is about physical workspace. So maybe it's about an office closest to the restroom or closest to the parking spot. It could be about special equipment or furniture. It could be about telecommuting. So maybe that's working from home, or maybe it's just from a different location than you would be otherwise. The second category is about schedule. So maybe it's going from full-time to part-time, or a flexible schedule. So on some days you work these hours, on some days you work these hours. Or maybe it goes from, instead of working 5 8-hour days, you're going to work 4 10-hour days. Whatever configuration makes the most sense for you. And then the last category is sort of everything else. So it could be about using technology. So is there software that could be helpful? It could be about a change in policy. So is there a policy about certain things that you need to wear and you're being impacted? Could that policy be changed? It could be about shifting responsibilities entirely. So most of the time we do more than the bare minimum that is, we do more at our job than those essential functions. And so can those other things be passed off to somebody else? And then finally, it could be about a change in job entirely. So is there another type of job that makes sense for you right now? Now, employers don't have to create a vacant position for you, but if there is one open and that you are qualified to take, that could be an accommodation. Now, as I mentioned, I think accommodations are so incredibly important and so underutilized. We have lots of resources, including a quick guide, a checklist, and one of our animated videos. So you can check those out if you have more questions. We also have a archived webinar about taking time off that goes into detail about FMLA and state leave laws and employer policies. For time today, I'm gonna leave it there, but of course I'm happy to answer questions. But I did just wanna spend the last little bit talking about disability insurance. So disability insurance is often misunderstood in that it really is only about making up for lost income because you cannot work. And so every insurance policy is going to be a little bit differently, but it's going to pay you a percentage of your monthly income that you were getting when you were working, or you would be getting if you were working. And it can help pay for expenses not related to the expenses that health insurance covers. So mortgage and rent and groceries, your living expenses. There are several different options for disability insurance. There are private policies, and those can be both short and long-term. So short is generally for disabilities that last between 6 and 12 months. Long is generally for disabilities lasting longer than 12 months. Sometimes these are offered through an employer. Some are ones that you can purchase directly from an insurance company. So AFLAC is a common example of a private disability insurance policy. Now, a handful of states have state disability insurance policies. So California, for example, you pay in through your payroll taxes, and then you have access. And these are short-term disability policies. And again, more information about these particular states on our chart of state laws. And then finally, there are 2 federal programs. Both programs are run through the Social Security Administration, and both are long-term programs. We have lots of resources on our website with more detailed information, but I'm going to give you sort of the highlights tonight. So there's 2 programs, and for both of those programs, you have to meet the Social Security Administration's definition of disability. Remember how I said we're going to have different definitions of disability? So this is different from the ADA's definition. Under the Social Security Administration, you are going to be considered to have a disability if you cannot do your job, you cannot adjust to a new job, and your disability has or is expected to last for at least a year or result in death. Now, what's interesting about this process is that it is a federal program and it's run by the Social Security Administration, but the entity that actually decides if you're eligible or not is actually a state agency, and it's called the Disability Determination Services. But it's tricky because we get asked a lot, well, wait, can I apply for disability while I'm still working? And the answer is, it depends. This is the 5-step disability determination process. And the first question is, are you working earning more than $1,260 a month? This is referred to as your substantial gainful activity amount. So if you are working earning more than that, it ends right there. You're not going to be considered to have a disability. But if you're working earning less than that, then you go to step 2. Step 3 and step 4 typically aren't where people get stuck. It's step 5. So can you adjust to any other type of work? And there is a big giant book that the Social Security Administration looks at to decide if there's another job you would be able to do with your qualifications. Now, the 2 programs are Supplemental Security Income, also known as SSI. And with that program, you have to have a low income level and a low resource level and fall into a specific category, be over 65, have blindness, or have a disability. So typically, Medicaid is the health insurance option, and SSI is the disability insurance option that go together. Now, SSDI, Social Security Disability Insurance, is for individuals who have worked and paid into the system enough. And you generally need to have 40 credits in order to be vested in the system, and 20 have to be in the last 10 years. So generally speaking, if you're older than 31, you have to have worked 5 of the last 10 years to be eligible for SSDI. It doesn't matter about your income or your asset level for SSDI. And then the amount that you get is going to be based on what you've paid in. So if you're Mark Zuckerberg, you're going to get more out of SSDI than somebody who makes $30,000 a year. But it is in fact capped at $3,011 for this year. Now, there are some significant challenges with SSDI. It is a lengthy process. The application can take up to 14 months. Actually, it can take longer than 14 months. I think the national average is about 14 months from application to approval. And no matter what, there's a 5-month waiting period from the date of your disability onset. But the good news with SSDI is that you could be eligible for back pay back to the date of your application, and that's because the Social Security Administration recognizes it takes them a long time to do this, so they're not going to penalize you for them taking so long. But then you could also potentially get retroactive pay for up to 12 months, and that's from the date you applied back to when your disability began. It's always going to exclude the waiting period, but the rationale for that is sometimes it takes a while for people to recognize that this is in fact going to be a long-term disability and they don't apply right away. So it takes them back until the date of their onset. Now, with SSDI, once you've been receiving payments for 24 months, you become eligible for care. With SSDI, the health insurance option is Medicaid. With SSDI, the health insurance option is Medicare. Now, I mentioned some advocacy and late breaking news opportunities. There are currently bills pending to eliminate the 5-month waiting period, because it really makes no sense to make somebody who can't work due to a disability go for 5 months without any sort of pay. And also there are some proposals floating around about eliminating the 24-month Medicare period. Now, I get asked a lot, well, do I need an attorney if I'm going to go through this process? And it's not required, but it can be very helpful, especially if your application is denied on the first try and you have to start going through the appeals process. But people will say, well, wait a minute, I can't work, so I don't have any money. How am I going to pay an attorney? Disability attorneys are actually paid on a contingency basis, so they only get paid if you are approved for SSDI. And the amount that they get paid is capped by law at 25% of your back pay, typically up to $6,000. Now, some cases might be more if it's a really crazy complicated case, but they have to actually get it approved by a judge if it's going to be more than that. Now, when we talk about how laws can fit together, one of the areas is in FMLA, which is the ability to take time off, and disability insurance. Because FMLA is job protected and health insurance protected leave. So it actually provides sort of a bubble for somebody for up to 12 weeks if they're eligible. And even if someone thinks they're going to be gone longer than the 12 weeks, that's 3 months where someone doesn't have to worry about what they're going to do for health insurance. So if you are considering leaving a job or taking leave and you have questions about how this all might work together, take a look at that quick guide link at the bottom of the screen, because it goes into much more detail. Now, we often talk about this information with respect to puzzles and how these puzzle pieces can fit together. So if you think about Jane, she has been recommended to go out on disability, but she also has 3 weeks of vacation and 3 weeks of sick. Her employer is covered by the FMLA, and she has a short-term disability policy. So what are the options? So this is how it all comes together. She can take 12 weeks of job protected leave under the FMLA. And during that time, she takes her 3 weeks of sick time, her 3 weeks of vacation time, and the short-term disability for as long as she needs it. So the blue is what's providing the money. The green is what's providing the job protection. Now, think about Mark. So Mark has 3 weeks of vacation, 3 weeks of sick. a short-term disability policy, and he thinks that he's going to need to be out for up to 15 weeks. So here's how that works. Sick time, vacation time, the short-term disability, and that's going to be what provides the money. Over here on the left-hand side, the first 12 weeks of leave are going to be through the FMLA, which is the job protection, but FMLA only lasts 12 weeks. So now he might be able to go back to his employer and say, as a reasonable accommodation under the ADA, could I have 3 additional weeks of leave to get me to the 15 that I need? So I know I didn't go through extensively the FMLA, but I just wanted to show you how all of these laws may actually be able to work together to provide the most amount of protection for somebody. Okay. Now, if somebody has been on disability insurance and they're thinking about maybe going back to work or starting work, there's often a lot of hesitation because they don't want to lose their health insurance benefits, or what happens if they start to go back to work and then they find out they really can't? Do they have to start the disability process all over again? And the good news is the Social Security Administration has set up several programs to help ease that transition. And collectively, they're referred to as work incentives. But basically, they allow somebody to continue receiving their Medicaid or Medicare, respectively, while they start to go back to work. And they have a whole host of training and occupational therapy programs. But then there's also a trial return to work period. So basically, you get 9 months every 5 years to figure out if you can go back to work. And you only count the month of work if you've earned at least $810. So if somebody starts to go back to work, earns $600 for the week, and then finds out, I really can't go back to work due to my health, that month isn't going to count for them. If they try again the next month and they earn $900, that month does count. And like I said, you get the 5 years to look to see if they've earned up to the 9 months. Now, I did just want to mention that things are a little bit different for children and young adults. For individuals who are under the age of 18 and have a disability, they may be able to get access to SSI if they're not earning more than that substantial gainful activity amount, which was the $1,260. But the trick here with minors is that not only do we take into account the child's income, but we also look at any family members who are in the household. And there are some allocations and subtractions that they do in order to figure out what that family member's income is. But in addition to having a low income, they have to have a medical condition that results in a marked and severe functional limitation. That's the Social Security Administration's language. Now, there are also some options for minors to get dependent benefits. So this is if a parent is receiving Social Security, retirement, or SSDI. A child who's under the 18 can actually collect up to 50% of the parent's monthly benefit, and they don't have to have a disability. And those benefits can continue until they turn 18 or they get married. So again, for families with the parent who has a disability, this is an additional potential source of income. And then there are also SSDI benefits for what are referred to as disabled young adults or adult children. I know it sounds bizarre, but basically it's for a child who is either disabled at 18 or a young adult who the disability began before they turned 22 could also collect on their parents' benefits if the parent's receiving Social Security, retirement, or SSDI. So I know I went through that really quickly, but I did just want to mention that there are some additional ways for younger individuals to have access to these programs, and the Social Security Administration has quite a bit of information on their website about that. And then finally, because I can't possibly go through a whole presentation without talking about COVID these days, I did just want to recognize and acknowledge that people might have some questions specifically around COVID, and we have been creating resources for the last 3 months to try to help people navigate the new laws and benefits that have been passed in the last 3 months. So Congress has passed 4 different pieces of legislation in addition to everything that's going on in the state levels. But specifically the question we're getting right now as states are reopening is around compromised immune systems and heading back to work, and what rights do not only the individuals with the disabilities have, but also the caregivers for fear of bringing the virus home to their loved ones who might have compromised immune systems. So these are all the places where you can go and get some more information. And then fortunately or unfortunately, there are a whole host of other healthcare related legal issues. And these are just some of them that we have resources available on the website if you have questions about. We want you to be able to find that information. I also should have mentioned earlier that all of the services that Triage Cancer provides are provided for free. So we never want that to be a barrier to somebody, and we just want people to be able to get access to the information. So I certainly hope that you'll continue to have a relationship with the organization and check in on the resources. And I am happy to take questions. It looks like I have 11 minutes.
Hey, Monica, thanks so much for that. That was so informative. And I just want to let you know that I had written down a bunch of questions that I know that our community might ask as well, or have questions about that I get asked often. And you checked almost all of them off in your presentation. So
awesome.
That's really good. No, you did a great job. So we really appreciate that. Do have a couple of questions. So I was just wondering, can you maybe talk a little bit about, and sorry if you already covered a little bit of this, but compassionate allowance?
Yep. So with the Social Security Administration's disability programs, there are a couple of programs that are available to speed up the application process. Because as I mentioned, that is a lengthy process and it can take over a year. So there are a handful of programs. One of those programs is called the Compassionate Allowances List. And it's literally a list of diagnoses that the Social Security Administration has determined that if somebody has one of those diagnoses, they are presumptively eligible for the SSDI or SSI programs. It doesn't eliminate the 5-month waiting period for SSDI, it just speeds up the application process. So generally speaking, what we suggest is if somebody has an illness or diagnosis that's on the compassionate allowances list in their application, to make very clear that they're using the exact diagnosis the way that it is on the list, because the Social Security Administration actually uses a software to scan the applications to see if it picks up certain words, and then your application gets routed differently. So it's always helpful to use exactly the term that's used in the list if that's your diagnosis.
Great, thank you so much for explaining that. It looks like Sean and Allison have a question, so if we can unmute them and let them ask it, that would be great. Might just take 1 second.
Hey there, thank you for this presentation. It's really, really helpful. The scenario that we have is that my husband, Sean, has been on disability for a number of years, and I am an independent contractor. And so we have a 13-year-old daughter. And so we do have insurance through the marketplace, and it's a good plan. It's a platinum plan. But I have a potential opportunity to take a typical job that includes insurance, but we're in, and it will offer family insurance, but we're concerned about Sean losing this platinum plan that he has that has worked really well for him. And so I guess the question is, if our daughter and I take my work insurance, is there the fear that he might lose the marketplace insurance? Because they often ask, could you be getting insurance through your spouse? And then up until now, the answer has been no, but in the future, the answer might be yes.
Fantastic question. The good news is that typically they're not going to drop him completely. But why they might be asking that question is if you're receiving any sort of financial assistance in the marketplace. Because the way that the financial assistance works is you're only eligible for it if you aren't eligible for adequate employer-sponsored insurance. So that could potentially happen if you were to take this job and you and your daughter go on your employer's plan, he stays on the marketplace plan, he likely wouldn't have access to the financial assistance. That being said, you'd have to do the math the way we talked about it to see if losing that financial assistance was worth not having to change plans. But I would also suggest that you look at the employer plan that's being offered and see if it's comparable to the marketplace plan, and make sure that all the doctors and networks and prescription drugs and all of that would be covered.
Mm-hmm. Okay, that's helpful. Thank you.
Good, I'm so glad. Good luck.
Thank you so much. Let's see, I don't see any other hands raised at the moment, so I'll just ask another question that I know commonly comes up. So can you speak at all, and maybe you can't, but if you can, speak at all to how it works with international patients? So say an international patient needs to access care here in the US, is there any special program or waivers that might be available for international folks?
In terms of immigration or in terms of health insurance status?
Well, it's a good question, I guess. Can you speak to either or both?
Sure. So immigration is tricky, especially right now. Even pre-COVID, with this particular administration, immigration has become more of a challenge. But if someone were able to kind of clear that hurdle, most of the time, well, see, it's really tricky to speak in abstract because it would depend on what somebody's immigration status was. If these that absolutely be able to get health insurance, even either through a job or through the marketplace, because that person would be lawfully present. But it's harder when if someone came like on a visitor's visa to be able then to buy insurance. That's unless they were showing that they were moving here permanently, and then that could potentially be a qualifying event. So it's really tricky to talk about immigration in sort of the abstract because every situation is going to be different. But if people do have specific questions, I'm always happy to they can feel free to reach out, and I'm always happy to try to figure out the answers.
Awesome, thank you, I appreciate that. We do have one question in the Q&A box here, so I'll just read it to you. It says, I currently work as a paramedic, and at the beginning of COVID-19, my transplant doctor wrote a letter stating that I need to be out of medical leave because my lung function was about half of what it should be. I'm assuming maybe on medical leave is what that's saying. And I would not do well if I contracted the virus. My HR department told me I was not eligible for FMLA. Is this legal for them to deny me this? They also told me that I could get my doctor to qualify me under the ADA, but I have never been diagnosed with a disability. He was very surprised by this.
Okay, so there's a couple of different parts to that. First of all, I can't give you legal advice, but with respect to the FMLA, I would want to know if you had met the requirements for the FMLA. So worked for a large enough employer, you've met the hour and month requirements. If you were eligible, I think the issue could potentially be that fear of contracting a virus isn't a serious medical condition by itself, and that's what the FMLA is about. And we're hearing a lot of similar concerns. And on that slide, where I say like employment and COVID, there's a link to our blog category, and we have a blog that actually lays out all of the potential laws and ways that somebody might be able to take time off and actually receive some pay potentially. So I would definitely recommend that. But keep in mind that there is an exemption where employers who employ healthcare workers can actually exempt their employees from those provisions. And so I don't know if that's another piece to your puzzle, given that you stated you're a paramedic. So I know that, again, that was sort of a non-answer answer, but hard to talk in abstract without more details. So feel free, on the front of my slide deck, I gave my email address. You can feel free to reach out and we can try to parse through some more of the details.
Awesome, thank you. We have time for, I think, one more question, and I see another one here in the Q&A box. So it says, my husband joined Medicare after 24 months on disability because we were told there would be a penalty fee for every month that he didn't join Medicare. Does that fee continue forever? He currently has coverage and doesn't need the Medicare, but he has stayed on it because of the penalty that we had heard of.
Okay, so what it sounds like, and I'm sorry if I'm putting words into your mouth, but how I'm understanding that question is that he's on disability and he's eligible for Medicaid, but maybe he's covered through your insurance at work, so getting the Medicaid, excuse me, not Medicare, Medicaid, Medicare wouldn't make sense. When somebody has other creditable coverage, like an employer plan, they don't have to pick up the Medicare and there isn't a penalty, assuming it's creditable coverage. Once that creditable coverage ends, like let's say you were to retire, then he would have a special enrollment period into Medicare, where then he could make his Medicare decisions and he would not be eligible, or he would not be charged that penalty. That being said, some employers will say, if you're eligible for Medicare, you have to at least sign up for Part A and sometimes Part D, in addition to our plan, and then Medicare becomes the first payer and the employer plan becomes the secondary payer. So before dropping Medicare, if that's what he decides to do, I would just definitely double check that the employer plan or the other type of coverage that he currently holds doesn't require that he be on Medicare. But in terms of that penalty, if he has other coverage, he wouldn't be charged that penalty as long as soon as that coverage ended, he picked up the appropriate Medicare parts. But to answer the second part of your question, if someone were to be imposed that penalty, it is a penalty for life. You guys are asking fantastic questions where I'm having to give very long-winded answers, so I apologize for that.
Oh, no worries at all. It's actually about time to wrap up. So I appreciate you so much. Your presentation was so informative. I'm so glad you were able to join us. And I will certainly pass along any questions that I get. And, you know, hopefully you and I can work together to help people get the information they need. But yeah.
I will upload to the Slack channel a version of the slides that isn't wonky. So I have those challenges, but I'll do that too.
Perfect. And I did post some of the resources that you had addressed earlier in your presentation in there as well. So hopefully folks can get the info they need.
Sounds great. Well, thank you so much for having me, and thank you to all of you for hanging out for an hour. I appreciate it.
Thank you.
Have a great rest of the meeting.